My talk is on wide field angiography. Already, most of the things have been covered. Where the wide field angiography can be used, or what is its utility? Basically, screening of fundus periphery, where you would like to know the vascular abnormalities, capillary non-perfusion areas, NVs, tumors, vasculitis, and it will help in early diagnosis, monitoring the treatment part, as well as the planning the treatment as such, because you know now the diagnosis. The classic fundus camera, as already discussed, this is giving you the view of 30 to 50 degrees UTDRS fields, but we are using this spectralis, Heidelberg spectralis machine, which gives 110 degrees, and if you tilt it, it can go up to the periphery. As I know, important thing is that you are seeing a single wide field image, same center to periphery, and it gives you the complete image. While in montages and others, you get a single field, or either supratemporal, supranasal, or inferior. So this is the thing where the multiple diseases you can diagnose by just in a single click, and with the optos as well as on the angiography also, in a few seconds you get the various types of images. So today's talks will contain the pediatric cases, PDR, diabetic macular edema, hypertensive retinopathy, ocular ischemic syndrome, VRO, CRVO cases, peripheral vasculitis, uveitis cases, retinal angiomas, and some miscellaneous pathology. This will be again repetition of Prashant's talk. This was previously we were getting the pictures up to this 50 degrees, but we know that with the wide field, you know that the neovascularization pathology which occurs at this junction of perfuse and non-perfuse areas, and where you can see the multiple neovascularization as well as the earmarks here. Here also you can see this is a wide field. This whole area is ischemic. So you are now going to plan the treatment accordingly, as well as you know that there is a NVD also. Here in this case of PDR, already treatment was done. The periphery was left behind or missed on angiography, wide field angiography. You know that this area needs to be taken care. And this is a PDR case with neovascularization of the disc, NVD. You can see the n number of multiple areas of capillary non-perfusion areas, and in other eye NVs also. This in a single click or single images you are able to see the extent of the capillary non-perfusion. So the treatment becomes easy to plan it, whether it will require only injections or surgery, lasers, and how many times it can be given. This is another case. Here again you can see that capillary non-perfusion areas have been extensive 360 degree and 360 degree NVAs at the junction of perfuse and non-perfuse retina. Here also you can see. Another thing is that this PDR case, clinically it was little bit hemorrhages versus this, but when you do the angiography, you can see plenty NVAs are there, and it will give you the guideline how to manage this case. Here you can see that whole area is CNP areas. This is another case of PDR with multiple NVAs. In cases of the astrodialysis, it is very difficult to say that this is a PDR case or not. But if you do the ultrawide field angiography, you will get the idea whether this is a PDR case or not. This is again in a Day's cataract also, you can do the angiography and you get the idea whether this is a case of PDR or not. In borderline cases, this was a well-treated case, and we were feeling that there is no NVs. But when we do ultrawide field angiography, you can detect the multiple NVs in it, and you will add the treatment in the form of injections or lasers. This is again, there was a pseudo sense that you are treated well, but these areas were remaining, and this is a common cause of macular edema. Particularly, we don't know why it is not responding. But peripheral capillary non-perfusion areas are very much responsible for cystoid macular edema or DME, and that is missed. Now, if you take care, it will be cured. Then again, this is a OCT angiography showing the ischemic maculopathy. But on the periphery, these slides you can see the extent of the new non-perfuse areas, which usually are not noted. Nowadays, there is always a debate whether the PDR requires laser or only anti-VEGFs can be enough. But in my practice of 25 years, and you all are seniors, we know that patients are coming from almost 16, 17 years old patients are treated 20 years back only with PRP, and they are doing well. In between, they have not taken anything. It is just the matter of how properly you have done the PRP. If so many areas of non-perfusions were remaining, so obviously the patient was progressing and not responding to any treatment. This is again a case of PDR NVD where someone has treated, and this after angiography you can see this. Lots of areas where non-perfusion were there, and it requires additional treatment, and that information you will get only on the basis of wide field angiography. Then there are certain hypertensive and retinopathies. We don't know the hypertensive retinopathies can cause only peripheral vascular occlusions and neovascularizations. These things can be detected on ultra-wide field angiography. You can see that on Pandus photograph we were suspecting something, but we did the ultra-wide field angiography, and it was a bilateral neovascularization process, and they manage very well with the laser. Then another hypertension with branch retinal artery occlusion. You can see this, and on angiography you will know how much is the extent of this ischemia. And this is angiography is nowadays very important. I have done almost 6-7 cases of CRO operated vitrectomy were done. 2 were successful, 4 were not successful. But before doing the surgery, this angiography will help how much extent of the ischemia is there, and whether this patient will help for after the surgery or not. Otherwise, you will do a big major surgery in such situation, and it will be wastage of the time and wastage of the everything. So this is again a case of central retinal artery occlusion. You can see that predominantly it is inferior branch artery occlusion. Then in cases of central retinal vein occlusion, it is always a debate of non-ischemic versus ischemic CRO, and the major differentiating point is, apart from clinically, angiography helps here. Over a period of time, it is called as 90 days glaucoma, neovascular glaucoma. We know that within, if it has to convert into the non-ischemic retinopathy, the ischemic CRO, then you have to keep on continuously monitoring whether it is converted into the ischemic changes, and this can be mapped on the photograph itself and see that whether it is progressive or not. This is again, you can see that there are so many non-perfused areas, even though we were treating it as a non-ischemic CRO. But on ultra-wide field angiography, we are able to know now that there are still some ischemic areas. This was a non-ischemic CRO. After a few days, he came with the diminution of vision. Then we did the angiography. Now you can see that it is converted to the ischemic CRO. Same thing here again. This is a combined case of branch retinal artery occlusion with CRO. Here you can see that how much extensive non-perfusion is there. That itself will give you the diagnosis immediately to the patients, whether to further manage, do the surgery or do the extensive treatment or not, and whether it is going to help. Then this BRVOs with collaterals, it was our impression that if collaterals are there, that is a well good going thing. Nothing will happen like in a heart. We know that collaterals are formed means you are not going to develop the myocardial infarction. Same thing was there, but you see that these collaterals were there, but there was a leakage from here. There was progressive lamellar hole formation, and lots of area was ischemic beyond the collaterals also. This needed to be treated and addressed, and that is possible only because of wide field angiography. Then even in a simple BRVO cases, we treat casually. How much to be treated is not done. We think that it is only sectoral PRP. Now here you can see that lots of area is remaining, and it was not need to be treated and addressed. Otherwise, usually we treat in that quadrant only and expect that there will not be edema or will not be further neovascularization and TRD. Here again, this is ultra-wide field will give you that is a hemicentral retinal occlusion with retinal edema again. Another case is that ultra-wide field angiography, it will again give you the idea of this is a video angiography. You can real-time picture you can document and see that whether where occlusion is there. This was a case of ocular ischemic syndrome, but in cases of BRAO, CRO or other vascular occlusions, if you want to do, you can see directly the early phases angiography or video angiography of these patients. Then here also you can see the ocular ischemic syndrome cases. Lots of scapulary non-perfusion areas are there, and this is another case of ocular ischemic syndrome. Here also you can see that already Prashant has shown many pictures of Takahashi, but we have found that these are almost, it was a carotid occlusive diseases. This was again bilateral case of ocular ischemic syndrome. Here another, you will see some pediatric cases, FUR cases. You can see the temporal, some changes were occurring. It was difficult to say that this was a dormant form of ROP or it is a FUR, and we don't do the genetic testing and all those in our setup. But angiography gave us that there are straightening of the vessels and peripheral ischemic areas as well as the new vascularization have been developed and was managed well with the laser only. This is another case of FUR. You can see the exudation and all those in the periphery, temporal periphery particularly, and which leaking vessels and non-perfusion. It is very well manageable with the laser itself. Then this is another case of FUR with dragged macula. With this dragged macula also patient was having 6/6 vision. Over a period of follow-up, she developed the macular hole and there was a leaking areas which we were not knowing. But when ultrawide field angiography was done, usually we neglect such types of cases, unilateral falciform folds, or if there is a drag macula, we say that it is like that and some congenital defect is there, accept it and manage. But when we did this angiogram, we come to know that there is a vascular non-perfusion areas, there is a cascade. We did the surgery because of macular hole, and her 6/6 vision was retained, and how she is managing, God knows. In one eye it is central fovea, and other eye it is eccentric fovea, but still it is there. Then another case of Coats disease. You can see this is a 13-year-old girl, Coats in girl. In peripheral eye you can see the telangiectatic vessels. This is all around the fundus. See, these types of pictures are very rare from here. We have managed it since last 3 years with the laser only, and still doing well. See this picture, very classical pictures of Coats disease, in that too in a female. Then this is a Coats disease, already Prashant also has covered. Peripherally we don't know what is happening, but if you do this angiogram only, you know. This is another case of Coats disease. These are the telangiectatic leaking vessels, and this is one more scar was there of congenital toxoplasmosis. This is a Coats in adults. You can see that peripheral lesion. What was it? If we were feeling a retinal angioma or tumor or something, but we did the angiogram and then found the telangiectatic vessel, and it was very well managed in Coats in adults. Then this is a congenital retinoschisis. You can see this one. There was an inner layer breaks, large wide breaks were there, and just out of curiosity we did the angiography, and you see that there is no blood vessels at all in those areas. Then there are certain uveitis cases where you benefit by ultrawide field and angiography. Here you can see the early phases, wide area of papillary non-perfusion, and later on there is a leakages. Same thing, then vaso-occlusive disorders are there with the cystoid macular edema. You can see that this vaso-occlusive retinitis. Then many cases of pars planitis, cystoid macular edema. If you do the wide field angiography, you will find some vascular abnormalities or phlebitis in the periphery. So they require systemic treatment. Your local treatment won't help. Then this was a Behçet's disease. When patient presented to us was like this, we managed with the systemic therapy, but he was not tolerating. Again, further progress when did the angiography. You can see that for the extensive areas, and this is almost a 32-year-old boy. So this was a Behçet's, and now we have started the treatment for Behçet's by and therapist. Then this was a Ills-like disease. Then when angiography was done, this was again vaso-occlusive disorder. So we did the whole investigations for the antibodies and all. Then she was turned out to be ANA positive. Then Ills vasculitis and all these are very common. We know that how much is the extent of the CNP areas. If you don't address it, it will keep on recurring and will cause the blindness. This is again a vaso-occlusive vasculitis or retinitis case where on ultra wide field angiography only you can find out the exact pathology. Otherwise, such types of things are missed by expert retina surgeons, also retina specialists also. So in conclusion, it is necessary to know and to confirm the exact diagnosis before deciding surgery, before seeing the response to the treatment. On to add on the treatment, you need ultra wide angiographies. We don't do repeat the angiographies, but here we know that it is a safe procedure. In my 25 years of practice, we do several times of dye angiography, but hardly one or two patients got a little bit of itching and anaphylaxis, and it was manageable. So there should not be a fear of dye angiography. Extent of capillary damage and all the severity of the pathology, we can get idea before starting the treatment itself. So the counseling of the patients and planning of the treatment is very much possible before starting itself. And most of the times we know that there are some hidden pathologies which you were thinking something and you come across with some different diagnosis. So it is very important before deciding the surgery and treatment. And now this is a picture of OCT angiography. Wide field OCT angiographies are now available in the market. One can see this, even though the cost is high, but obviously you can try anytime. Thank you very much. Thank you for kind listening.
2.3 CR is I'm doing. So over the last 5 years, my fluorescein angiographies have plummeted. And ICG angiographies, I send once in 6 months or once in 4 months. So if it is just ultra wide field imaging, then because the major decision maker is the cost, then Optos is still my number one choice, which is what I have. I don't think anybody will regret the machine that they have bought. But Optos has this option of color fundus, autofluorescence, and you have red free and choroidal image, what they call a choroidal image also. But you don't have angiography. You can't upgrade that machine to an angio. You'll have to buy some. Correct. So unfortunately, the angio model is double the cost of the one without. So how many angios are you doing? Because then you will not use a conventional angio. Or you may wish to continue with your conventional angiography and use this only for ultra wide field angio. I don't know. Yes.
Exactly. So I think if you
because we are not doing FFA basically because we didn't have idea what it can explore.
Exactly.
The thing is that at this stage, we don't have any experience. You have missed the things.
So the historical perspective is that no, doing angio for the indications that we were conventionally doing angio for. Doing angio in patients with diabetic retinopathy, conventionally now is almost non-existent. Doing angio in patients with AMD is almost gone. So you are doing angio in very new indications for these kind of indications. सबको करना है.
I would sum it up very well as Vatsal sir is saying. It is not that, yes, because our standard fundus angiography was not giving us much added information, now we have really a lot of indications where you can definitely consider doing it. And that's why at our center, I would not say the angios had plummeted down significantly once the AMD, we thought we are not going to. But this now, when you are more suspicious, these are adding. Newer indications is increasing the number of angios being done at our center now.